My name is Shaun McCann. I'm conducting a series of expert interviews on behalf of the European Hematology Association at the annual meeting of the American Society of Hematology, which this year is in Orlando, which is in Florida. And with me I have Anjali Advani, is that? Oh, that's right. You're very welcome, Dean. Thank you for coming along.
Thank you.
And she is Professor of Medicine in the Cleveland Clinic, Lerner College of Medicine of Case Western Reserve University in Cleveland, Ohio. That's a mouthful. And she's an expert on ALL. So my first question is going to be, is ALL in children and ALL in adults, are they two different diseases? Because they have two different expectations. The outcomes are different.
That's a really good question. So I think there are a couple of things. I think there definitely is a difference in the biology of ALL. So as you go from children to adults, so children have cytogenetic abnormalities such as the TEL-AML1 gene, and which has a very, very good prognosis. They have a higher incidence of hyperdiploid ALL, which again carries with it a good prognosis. In adults with ALL, we see a much higher incidence of the Philadelphia chromosome, which, although things are changing with that disease, now that we have targeted therapies, that typically has been associated with a worse prognosis. And there also, as you go from children to young adults to adults, there's also a higher incidence of the PH-like ALL.
We'll come back to that in a minute.
Which we'll come back to, I know.
Okay, let me interrupt you and say, why do you think, does anybody know why Philadelphia chromosome is more prevalent in ALL as we get older?
That's a great question. At least I don't know the answer to that. I think clearly it looks like it does increase with age, especially as you get to people, 55 and to 60 and over. It's about, almost half of those patients.
Old people like me, yeah.
So it's a very interesting
And we have
question.
no idea why, have we?
No.
Well, as you say, with the advent of TKIs, the prognosis, at least in the short term anyway, is certainly better. Okay, tell me about this Philadelphia chromosome like ALL. I know nothing about that, so educate me, please.
So that's really interesting. So it turned out that the children's group, pediatric group, looked at these children that were relapsing with ALL, because in general, children with ALL, as you mentioned, do very, very well. And so when they looked at their gene expression pattern, it turned out it looked like PH-like ALL. It looked like pH-positive ALL, but they were not able to find the Philadelphia chromosome. So then they interrogated things further and basically were able to show that these patients had various kinase fusions, and they could involve fusion partners with things like ABL, PDGFR, CRLF2, JAK2, and so what's more complicated than with pH-positive ALL is there are multiple fusion partners. Right. But interestingly, in kids, you see more of the ABL fusion partners that may be candidates for therapy with things like imatinib or dasatinib.
TKIs in a way, yes.
And with younger adults or adults, you're seeing a higher incidence of the JAK fusions, which may be candidates for drugs like ruxolitinib. Right. So there are ongoing trials now. And the hope is the prognosis of these patients has typically been very poor, with a very high incidence of MRD positivity after induction, which I know we're going to talk a little bit about. And so the question is, can you, with TKI-based therapy and chemo, now improve their prognosis similar to what we've been able to do with pH-positive ALL?
So you touched on MRD, so I'm going to come back to that. So are you measurable or minimal?
So I think I'm getting to be more measurable, although in my talk I did discuss minimal. And I think, one of the reasons is now the testing that we're doing for minimal or measurable residual disease is really becoming more sensitive. So it's becoming I think in ALL, unlike other diseases, I think it is a standard of care and very clear that we need to do MRD testing. I think the more difficult part is now, as we're getting more sensitive assays, if you now use something like CloneSeeker, the adaptive technology that's very sensitive, do you make those decisions after induction, or at what point do you make
that's
those?
the next question. When is this a good or bad prognosis? I mean, what's the right time to do it?
It's a great, and I think it's partly, I think, dependent on the protocol. I think it's dependent on the sensitivity of your assay. It's dependent on what level you get after induction. I mean, if you have someone after induction that is MRD negative, their prognosis is excellent. And so that's kind of an easier guideline. But then if they're positive, at what level and what the rest of their risk features are, their white count, their chromosome testing, all of that, I think, factors in. Do they have the pH-like signature?
And if they're positive, what do you do? I mean, in practical terms?
Good question.
Do you change strategy? Or?
That's a great question. So, blinatumomab is now FDA approved for MRD positive B-ALL, but typically we're not doing that right after induction. And so, that, I think blinatumomab is also complicating things, because there are in general, if someone is MRD positive after X number of cycles and we're thinking about blinatumomab, typically those patients we also say you need to go to transplant. But there is this subset of patients that don't go on to transplant that do well. The problem is, I don't think right now we can really identify those patients. There have been studies looking at markers to kind of stratify those patients, but I think right now we just are not clear about that.
Okay, I mean, in terms of methodology, is flow cytometry the most widely used to measure MRD and ALL? Is that
so right now, I think in terms of the trials that have been published, at least in the U.S., that's true. In Europe, I think they've used more PCR-based strategies typically, but at least in the U.S., more of our trials and knowing kind of what to do with those results have been flow-based. And so I think that adds another layer as we now do the next trials. Most people are starting to switch to next-generation sequencing and clone-seq. So the issue is going to be really almost within the trials. If you can do both assays and then try to look at outcomes, I think that's going to be optimal.
Okay. I suppose flow is useful because you don't have to have a diagnostic sample. I mean, you can still do it.
Right.
More difficult, I know.
Right. Right.
Okay. Everybody is talking about CAR T cells, so let's talk about it. So have they come of age yet in ALL, and where do they fit in?
Yes, that's a great question. So, really right now, the tough thing in ALL is the only CAR T cell that's approved currently is for patients less than 26 years of age. Okay. And so that leaves a large number of the rest of our patients. There are lots of ongoing clinical trials. So Kite has the Zuma trial that's ongoing in adult ALL. I know there are other trials planned. And there are many other trials now trying to look at, bispecific CARs and other things. So I think the results are very, very encouraging in children with ALL. I think, in the FDA-approved indication, there definitely is a nice niche there. I think where we really are trying to go is getting them approved for adults with ALL, because, studies such as that published by Jay Park in the New England Journal of Medicine have demonstrated very encouraging results in adults with ALL. So I'm hoping that those drugs
will become real.
Will become real. But in the meantime, there are a lot of trials.
In terms of toxicity, are we pretty happy with that? We can deal with that now? The acute toxicity anyway?
That's a good question. So I think there's still work to be done in that. It does look like in adults with ALL, there have been more issues with toxicities, and the toxicities also seem to be somewhat more specific to products. And one of the adult trials by Juno closed a few years ago due to toxicities, but I think there's now a lot being learned about kind of what led to that. Yes. And so, I think getting back to your question, I think we are ready. I think it definitely the treatment has to be performed in a center that has experience,
Right.
that has a good ICU, that you communicate with the ICU, that has, neurologists that are available. And again, just realizing it's a little bit different in children versus adults.
Right. Right.
And also the amount of disease burden that's on board as well.
So when I was young, a long time ago, I used to do allogeneic stem cell transplants for adults with ALL. Is that redundant now?
So definitely, there's definitely still a lot of patients we transplant. I think there are a few things, I think, from this meeting in young adults with ALL that do not have high-risk features. There's a study presented by Matt Wiedewald that was done in collaboration with the CIBMTR. And in that study, it shows, at least in the young adult population, the outcomes were excellent with pediatric-inspired regimens and actually better than those patients that were transplanted. Now, there are lots of issues with this study because it was retrospective. There's not MRD testing.
Right.
High-risk patients, should still get transplanted. The second thing is I think we're starting to use MRD to really focus which patients should get transplanted versus not. But the third thing that I think is very exciting, and this may decrease the proportion of patients we transplant, is there are a lot of trials now looking at using antibody-based therapies such as blinatumomab or inotuzumab in the upfront setting. Those trials are randomized, but my hope is those trials will be positive. And, as those drugs are used up front, hopefully our relapse rate will be lower and maybe the number of patients we are sending to transplant will be less.
Will be less. Okay. The last point I want to ask you about is AVN. We used to everybody got the same treatment, but only, now we know that there are certain people that have a certain mutation which makes, but does that help you in terms of treatment? You can't decrease their treatment, can you? Or can you?
Yeah. That is still, I think, a very complicated issue because, it may, like you said, you may be able to predict a little better which patients are at risk. But right now we know steroids are very effective.
Yes.
So I think probably the biggest thing we have done is I think now we know clearly that risk increases with age. And we know from studies within the pediatric group that even young children versus young adults, that the same steroid regimens cannot be used. So in the COG 0232 arm, they actually had to amend things.
So reduce the amount of steroids.
In the one arm. And so, I think that's probably right now, as we go further, I think those things need to be studied more, but you're right, it's very complicated.
It's a brave person who will do that. But
yeah.
AVN is a pretty devastating complication, but I suppose you'd rather have AVN than be dead, I suppose, is the answer.
But I think definitely, the new trials going forward have recognized that correlates with age, and they definitely have adjusted the steroid dose to still give high doses, but not as high as, say, you would as in young children.
Right. Okay, listen, thank you very much indeed for sharing your thoughts with us.
My pleasure.
So for you young investigators out there, there still seems to be a role for allografting, although that hopefully will diminish over the next 5 or 10 years. And there are many new agents. So hopefully in adults, this disease now will be curable in the majority as opposed to the minority when I was treating adults with ALL.